And so if we start session one, going to slide number 5, I think there is one single message which we have all heard a lot in these last couple of months or so, that to try to flatten the curve, to try to reduce the spread of the COVID-19, and also to stay personally safe, staying home is really a key thing for patients with myeloma, and to use the precautions of hand washing and what I call physical distancing. I think that the distancing is one where we want you to stay physically apart from individuals who might be a source of infection, but we recognize that as with seminars like this, it's important to stay socially connected and to have a strong social network to try to get through this whole crisis situation together. So just some bullet points about the coronavirus itself. On slide number 6, it's obviously highly infectious, even more infectious than we had at first realized. It's spread by droplets, which can be from coughing and sneezing, both in the air and from surfaces where the droplets can linger from hours to even a few days. And so being very careful about cleaning surfaces when you're out and about is incredibly important. The biggest risk, without a doubt, is close person-to-person transfer for someone who is infected, even if they may not be symptomatic at the time, and even if they may not even realize that they are infected. We've started to understand some additional features about the disease. One strange thing is that if the infection is predominantly in the nose area, there can be a loss of smell. There also can be a variety of other symptoms, including GI symptoms, and rarely you've seen on the news some strange skin problems which have been occurring more so in children. And so the first polling question, which I think we'll all be interested to know the answer to, is are you, as myeloma patients, still sticking with the stay-at-home guidelines despite all these reopenings that are happening across the United States? So this will be coming to you now, and so if you could answer yes or no, we'll be interested to see if you are indeed sticking with the stay-at-home process. All right. Okay, so the answer is in. I don't know if you can see it. Can they see it on their screen? Okay, you can see it. Yes, 96%. So personally, I think that is fantastic, because that is the most secure way to stay safe. 4% no. And so there may be situations where you do need to get out and about, and with due caution. So with this first introduction, I'll be interested in feedback from our panel. And so, for example, Joe, how do you feel about the stay at home, and how do you see that transitioning as we move forward?
Yeah, thanks, Brian. I mean, I think, as we've often said, nobody knows the future. So we always have to be careful how concrete people feel about some of these things. But, you know, I'm very glad to see that 96% as well, because there is no doubt, whether we look at the example of New Zealand or other places, we can really contain this. And I think it's very important that people continue to do that. Of course, the looking forward, we can't stay this way forever. So I think it's very important for people to know what was going on in their local area. What are the recommendations from the health expert in their area? It would be different, of course, if someone's in New York or if someone is in northern Idaho. You know, we have such a variance within. But I think as we go through now, we're going to see some of the exact precautions that we can encourage people to do. Yes, indeed, stay at home is sort of the number one anchor, but there are multiple other things people can do as they do have to go out for their groceries, as they do start to re-engage in life, there are many other steps that we can take, and I know we're going to take time to go through those. So I do think we have to start opening up at some point, but I'm very glad to hear that people are still adhering until we truly see these numbers drop off, that they're staying at home.
Yeah, so thank you, Joe. So, Bill, the Seattle-Washington area has been strongly affected by this crisis. How do you see things moving forward there? I would assume that stay at home is still the number one mantra, but patients do need to come into the clinic and get back to some degree of normality. How do you see it moving forward?
Well, we've been in a lockdown pretty much for the past 6 to 8 weeks, but it is starting to open up now with limited activities in parks and trails, and there is a phase 2 where they're actually going to open up certain business activities that are able to have curbside delivery and pickup. But the whole underlying theme of this is social distancing, because until we have a vaccine or an effective antiviral that can control this, the infection when you get it, the best way is to avoid getting it in the first place, and that's where social distancing comes in. But our governor, who's taken a lead in this, has outlined a 4-phase process where things will open up every 3 weeks, as long as there isn't a rise in the numbers of cases that occur. So each of the steps that have come along, if it isn't associated with greater numbers of transmission of disease, we are going to slowly open this up. But it'll be the end of July before we're back to nearly full activities. And certain things are way off in the future, such as attending stadiums, events, sports events, concerts, and really even things like movie theaters. They're off in the future.
Absolutely, absolutely. So we're going to have to move forward, but just quickly, Joseph, what is the story in the Chicago area right now?
We are just a little bit behind of other states, but we are experiencing a high number of cases overall in Cook County in Chicago, and so the mayor and the governor of Illinois have been really working hard to monitor the data, and they are very cautious in giving dates. So far right now, what we have is still stay at home until June 1st, and there's no further guidance after that. So we keep on waiting.
Waiting to see, absolutely. So let's go forward right now. Next, I'm just going to give a little bit of a background of the timeline, which actually is helpful in looking at what might be the timeline moving forward. And so on slide number 9, I've just put in the middle China, which is where this COVID-19 first began in Wuhan. And the more that we learn about this, it seems that the original infection probably started certainly in December, maybe even tracking back a little bit into November. And so the live market in Wuhan, which we think was the source of the COVID-19 virus, was closed on January the 1st, which tells you that, back in December, the Chinese were definitely worried. And on January the 8th was when the first case of community spread was reported from Wuhan, at least publicly. One suspects that probably there was a realization of community spread that extended prior to that. But the important dates for us are the dates that the virus spread to Europe and to the U.S. And so early on, there was transmission from Wuhan to Seattle. And then, although we don't know exactly the date, there was also transmission to the San Francisco area in that mid-January time frame. And over to the right, you can see where that gave rise to very high areas of infection, both in Washington state and down in parts of California. What is interesting and important is in Germany, it seems that the first infection arrived in Munich, again in that mid-January time frame, and then the virus was picked up in close to Milan, Italy, shortly after that, also in mid-January. One key point about that is that it did seem that there has been some mutation in the virus and possibly even a new strain of virus that emerged, which may have accounted for the very serious infection rate that occurred in Italy. And also the fact that the COVID-19 crisis in New York seems to have predominantly come from Italy rather than coming. There obviously has been some transfer across all of the states from the West Coast, but mostly on the East Coast it arrived from Europe and mostly from Italy, also a little bit from Austria. So it's extremely important as we try to think about opening up and returning to normal activity is within our local population moving forward, as we dampen down the active infections and we have the possibility of new infections popping up, where are those infections coming from? Well, obviously a travel hotspot would be the key thing, and so right now there is very limited travel. Another source is super spreaders. What has been noticed is that among individuals who are infected, some have a very, very high virus load related to the virus reproducing much faster and to a much higher level. And even one such individual in a large group setting can contribute to a lot of infection in the population. And the same thing seems to be true within high-risk groups, and I've given you a list of them there. And we've heard so many of those in the news in the last couple of months. The situations of high density in New York, the ships where there has been infection, even truck drivers transferring the infection across the country. But within our own local population, as we emphasized already, the key thing is that physical distancing is the way to reduce the increase in occurrence of the infection, which is currently running at around 2 to 5% mostly, but in New York, for example, has gone up to 15 to 20%. It's important also to be aware that the risk factors for infection influence the likelihood of severe problems, and this map of the U.S. on slide number 11, the red areas show the areas where there's likely to be the most trouble, and that is where there are individuals with the highest number of risk factors, such as high blood pressure, diabetes, obesity, and chronic lung and kidney problems and the like, and also high-risk situations, for example, in nursing homes. And across the U.S., nursing home residents have contributed incredibly. A very, very high number of cases have actually come from nursing home residents. And you can see the pattern in the south and in the east, and with mostly a much better picture in the middle of the U.S. and on the west coast. It's helpful to compare the U.S. with other places. And I think for me, as a practicing physician in the U.S., it's actually very sad to see that a lot of other countries have done a lot better than the U.S. Some of the places where there has been a lot of trouble have been Spain and Italy and also the U.K. And this is related to when you comb through the haystacks. If you look at slide number 12, if you look on the right, at the top of the list are the places where a lot of COVID-19 testing has been performed. And when you do more testing, you know how much infection that you have and where is the infection so that you can do tracing and containment and try to limit the spread of the infection. And if you look at the bottom of that list, you'll see the United States is pretty close to the bottom. We have Ecuador below us, but most other countries are above us in terms of being able to have conducted tests to know where we have infection. And so this makes it really quite difficult in the US to reopen without knowing exactly what we're dealing with. So we need to pay close attention on slide number 13 to the major medical factors that can influence the likelihood of problems. Age is a factor, although we've seen that young people can also have serious problems, but percentage-wise, over the age of 65 and certainly over the age of 75 is a substantial risk factor. High blood pressure, cardiac issues, obesity, and diabetes collectively in the US, those have turned out to be the major sources of predisposing factors occurring in New York, for example. And those do link to the ACE2 receptor. On the surface of cells, there's something called the ACE2 receptor, and it can be modified in such a way that it's more attractive to the COVID-19, which hangs on to this receptor and can get into the cells and can reproduce. And when you have hypertension, cardiac issues, obesity, and diabetes, the receptor is modified such that this is more likely to happen, and this is what really predisposes these people to have more problems. Now, you'll see halfway down the list, we have cancer diagnosis, which is obviously myeloma, and so it's been a bit unexpected and surprising that having a cancer diagnosis is obviously a risk factor, but it's not the top of the list. And then below that, you have some of the other things which are key important factors, including social disparities, race. Obviously, we've heard a lot now about African Americans, Hispanics, and even American Indians. The Navajo have really been devastated by the COVID-19. And so the issues that have emerged have been many, and we have seen that COVID-19 really dominates the news that we all listen to each day, and one of them has related to the loss of jobs and the loss of so many resources, where food security has become a concern, both for those who are able to get it, where they need to decide whether to go to the grocery store or get home delivery, but the precautions that are necessary to avoid getting exposed during that getting the food process. But this is particularly a problem for the disadvantaged. And so I do have some good news. Just released is a COVID-19 emergency food assistance program that has been just been launched. And this is really wonderful. And Bristol Myers Squibb, previously the Celgene, they are important sponsors of this program, which is really wonderful to see. And I can perhaps just mention that it has been amazing to see how all of our pharmaceutical partners have been so focused on trying to contribute all different kinds of ways that they can help. And I can say that I do see moving forward that we will need their help and input to get through all these different issues that have been emerging. And so now we have another question. Most of you have been staying at home. However, the question coming up is, if you're a myeloma patient, have you tested positive for COVID-19? And so we're hoping that the answer to this will be no, but it would be nice to have that confirmed. Okay. All right, this is wonderful. We only have 1%. So we have over 1,000 people on this call, I believe. So that means that there may be perhaps most 10 people who have been COVID positive. And so perhaps we'll hear any concerns that have emerged from that. So 1%, that is phenomenal, excellent news. Okay, so we have time for questions and comments here. Hello? Yeah. Bill, I thought I would turn to you first and ask you what you think about the various risk factors for problems with COVID-19. You've had just a couple of patients that were affected, but my impression is I'm not sure if it's so much about the myeloma, but maybe some of the other cofactors that might predispose them to have problems.
Yeah, that's a very good point. So, as you know, and all of us know, myeloma is a disease of older patients with a median age of about 70 years. So, age alone is a risk factor if you develop COVID, and older patients tend to have more adverse outcomes. But in addition, older patients have comorbidities, cardiac disease, lung disease, hypertension, diabetes, all things that Brian has mentioned. But layer on top of that myeloma, which is a cancer of an immune cell, plasma cells, and as such, patients who have myeloma can have altered immunity and suppressed immunity. They don't have normal levels of antibodies most of the time, and they don't have normal immune responses to vaccines and other stimuli. Layer on that, in addition, the chemotherapy that's given that also can be immunosuppressive, and you can see that all of these things contribute to an increased risk for complications if you were to develop COVID-19. And so it is important to practice all the measures that Brian has talked about, and the best defense about this is not to get it.
Absolutely, absolutely. So Joseph, I'm wondering, in Chicago, I touched on the issue about food security and food sourcing. Do you have any comments about that aspect, either the scarcity for some people or the protections that are needed for myeloma patients to try to stay safe?
For the city of Chicago, we definitely have a problem with food supply. Our pantry and our non-for-profit organizations here have been calling for support and funding because they are definitely having an increased demand from citizens of Chicago, not just the cancer patient population, but it is definitely a worrisome situation when a patient with cancer also has to deal with food insecurity. We have definitely in our practice, we have our social worker and also our nurses are asking questions if there are anything that the patient is experiencing. It's very important that we ask the patients what's going on at home, how are they coping with the pandemic, and who are their support system, and making sure that there are no gaps that could potentially put the patient at risk or being isolated. Or that's not necessarily part of it. So.
All right. Well, thank you for that. So I think just to keep things forward, I think we need to talk quite a bit about some of the details that do relate to the treatment for myeloma patients. Some of the things that have been necessary in the short term, but our goal of trying to get back to as much of a normal treatment planning as possible. So if we look at the next slide, number 18, the main way in which a myeloma patient might be at risk is if they need to go in to the clinic for urgent care, although actually a number of the myeloma patients that I'm aware of that are COVID positive have actually become COVID positive because of contacts actually out in the community. But the big concern obviously has been to go in to the hospital where there has been such a focus on patients who are desperately ill with COVID-19. But some patients with active myeloma at a new diagnosis or relapse absolutely have to go in and get care in the safest way possible. A big question, which I'm sure we'll touch on in just a second, has been, should a patient go ahead and get an autologous stem cell transplant, ASCT? And the answer has been mostly no in the short term, but I'll leave it to Bill to maybe comment on some of the nuances of that. At the present time, cellular therapies such as the CAR T programs have been not accruing, but again, this is such a decisive therapy that moving forward, we want to see strong ways that cellular therapies can be utilized again. For some myeloma patients, having low blood counts is a concern, and so dose reductions have been recommended for those patients just to be on the cautious side. Also, high-dose steroids can be a risk, although they can also help with inflammation, which comes from virus infection. And a small point is that low vitamin D levels are not good, and so maintaining good vitamin D is a good idea. But what's been happening and what may continue to happen and what myeloma patients need to be increasingly aware of is that most centers, myeloma-specific centers for sure, have been switching over to telemedicine, where they have been using video chat or at least telephone calls or emails to communicate with the patients and organize planning so that the patient does not need to come into the clinic. There are also different ways to get the lab testing done so it can be done safely, or maybe skip the blood counts for a week or two if the blood counts have been steady. Also cut back on the frequency of the bisphosphonates, the Zometa or the Iridia for the time being. And as I said, maybe some dose reductions to make sure there's not neutropenia. And also perhaps use an oral agent, a proteasome inhibitor like Ninlaro versus Velcade or Kyprolis, although for a patient with active disease, it may be that every effort is necessary to try to get that IV infusion. But for example, Darzalex, there's a balance. Does the patient come in to get those follow-up Darzalex infusions or perhaps delay for now? And as we'll mention a little bit later, it's great news that Darzalex is now available as a sub-Q shot, so that is great. And also for quite a number of patients who are on clinical trials, it's helpful to know that some of the visits and dosing and things can be modified and still stay on the protocol. And so we are interested to know how many of you have in fact been getting your care using something like telemedicine, where you have a video chat or a telephone call or communicate by email, etc., without going into the clinic. And so if you can let us know yes or no on that, we'll be most interested. We do understand that in some parts of the country, the doctors' offices are not really set up for this, and we have had comments from a number of patients where they say they want to do it, but the doctor has not been set up to do it. But now there are billing mechanisms in place to be able to get it done, and even some of the HIPAA regulations have been relaxed to allow this to occur. Okay, so this is interesting. 64% have in fact been doing that, 36% no. And so we'll see, we'll maybe get some questions for the ones that are answering no, whether that's because it's maybe just not been available to them. And so let's go to another Q&A session. And so Joe, perhaps you could comment on this aspect of the telemedicine for now and how you view that moving forward.
Yeah, absolutely, Brian. You know, I'm seeing now about at least 3/4 of my patients by video, and that leaves those that really have to come into a safer clinic, as it were, where it's more easily to social distance and the like. I would like to add that, you know, it was very appropriate that we listed all those risk factors, but I also want to balance that by saying, you know, we have not seen and this is now a national phenomenon. We have not seen as many cases as we would have expected in heme malignancies in general. And I think part of that is because the risk may not be as high, and of course, you're the expert in the world myeloma experience, but also I think part of it is on this same vein of telemedicine. You know, our hematological malignancy patients have been taught to wash their hands carefully, to disinfect, to physically distance when necessary, to wear a mask when appropriate. So all those on the line today, that when you've been through a bone marrow transplant, all those things we taught you after a transplant actually are really coming in handy now. So I think that's part of it. And as I say, thirdly,
right.
I think the risk is lower. I think they've been taking the correct measures, and I think our clinics are safer because we've been very careful. I was discussing this very closely with a number of myeloma clinics in the New York City area, and they also would have expected to have more cases than they have. And I think part of that has been because of this. And the balance, of course, is that I think one of the risk factors, of course, is having very active myeloma. If you have real disease, as many of our patients do, we don't want to undertreat that for the risk of COVID. So every patient has to be looked at individually, discuss this with their physician. I have been concerned, having lived through the SARS epidemic that we had in Canada many years ago, that a lot of patients may not be reporting their symptoms and may not be followed up and may not be getting their treatment. And we find, unfortunately, later when we emerge from the epidemic that people are in this case, pandemic, people are in worse situations. So it's one thing if we put things on hold for a week or two or a month or even 2 months, but knowing how this is moving and how this is going to take a longer time, I really encourage people to discuss this exact point with their treating physician. Sometimes it makes sense to go to oral therapy or to reduce the frequency, but very often you need your treatment because active myeloma is a risk factor. Controlled myeloma will help reduce that risk factor.
Yep. Yeah, very, very important. And just to comment on one point that you raised, Joe, it's true that through the International Myeloma Foundation, we're in touch with groups all around the world, and it has been impressive, for example, hearing from Asia. So we have contacts, clinical trials group actually, with 7 countries in Asia, the Asia Myeloma Network. And within that group, there have been, actually, within the groups themselves, there have been no positive cases with COVID-19. And this emphasizes the point that particularly in Asia, there is a tradition of wearing masks if there's a concern about infection, very careful hand washing. Those kinds of things have definitely protected our myeloma patients. But in addition, it just does not seem that myeloma patients themselves and those that are on active treatment do not seem to fall exactly into a higher risk group. And it may be that the treatment itself shuts down some of the inflammatory or other processes that can be a danger with the COVID-19 infection. Bill, what thoughts do you have about the telemedicine? Has your practice shifted over to that, and how do you view that moving forward?
Yeah, I'm seeing about half of my patients now with telemedicine visits because in many cases the checkups involve really checking their lab assessment, talking to the patient, and asking them, how they're feeling. And this doesn't necessarily require an in-person visit. And as Joe points out, this protects the patient, but it also protects patients who have to come in because there's fewer patients in the clinic. Right. I actually think that the reduced incidence of COVID in our patient population is precisely due to the measures you've outlined, the hand washing, mask wearing, social distancing. These are things that most of our myeloma patients take for granted. And I think this has protected them through this pandemic.
Absolutely, yeah, very, very important point. So I agree fully. Okay, so let's move forward and get to the latter parts of this discussion about the COVID-19. A few different things that we need to think about moving forward. And so if we go to slide number 23, what do we need to know now? And so as I've mentioned already, as things open up, it makes a big difference how many individuals have been exposed in the area where you live, which could be much less in Arizona versus New York versus Washington or some parts of California. And then you need to be checking to be aware of if there is infection, where is that coming from? Is it coming from the nursing homes and you need to be cautious about contacts, or which other settings, like a meat packing plant or some other place where there have been pockets of infection? And then we need to be much more aware of the people who are truly at risk, the people who have comorbid conditions, the high blood pressure and the like, and particularly some of the racial factors, African Americans, Hispanics, American Indians, and others. Now, one point just to emphasize, this has been very much in the news. What is the role of antibody tests? And so on slide number 24, what I give for our patients are a number of links which discuss antibody testing. And so the simple answer about antibody testing is that it does indicate if someone has been exposed to the COVID-19, but it does not tell you if you're necessarily immune. And the problem recently has been that the tests are not that reliable yet, although the FDA has just approved a new test from Roche, which they say is 99% accurate, but we'll see about that. I think it's going to take some time, and we probably will need some newer antibody tests. But the issue is that even if you have a positive antibody test, does that mean that you can just go straight out into the community and that you're protected? We just don't know that yet. And so to discuss this, I would suggest those who are most interested might want to look at a user's guide to the immune system. Should you get an antibody test? One of the links that I gave you there, which I think goes into a lot of the different details that might answer questions that you might have. One big thing when we are stuck at home in quarantine is it is absolutely crucial to try to get out and about a little bit. And so it is definitely safe to go out for a walk, respect physical distancing, but try to make social connections in an appropriate way, wear a mask, and increasingly, and I'll be interested to hear from my colleagues, proper masks, medical type masks, are becoming more available, but if not, you can wear a cloth mask. And some exercise is really a good idea from all kinds of perspectives. And getting together, and this is a picture of the GoTo virtual support groups. We do have a whole group of support groups across the United States, and many of you, I'm sure, are members of those. And we have had the great honor and pleasure to lead some meetings with these support groups. And in fact, over 75 support groups across the U.S. now we're helping with the virtual GoToMeetings program to help people get together, to stay socially connected, to learn from each other, and have best ideas about how to move forward together. And so I don't know if there are any particular points that anyone would like to pick up on from those aspects. I think that trying to maintain the social connections for our patients is particularly important. So Joseph, what are your thoughts on that? No thoughts. Is the audio gone? Are we all right?
Okay. All right. I'm back. So
so sorry.
Practice we have, relax our policy. We're now we respond to emails to our patients, and we also try to check on other patients whom we know are living alone, and also we encourage our patients to talk to other patients and also do FaceTime, and also be active, be socially active in this time of social distancing.
Right. Okay.
I couldn't agree more, Brian. I mean, I find it almost paradoxical that we're all in one way segregated, but in another way, I've never felt more unified in a myeloma community than right now. You know, the things that the IMF are doing and so many others to try and bring patients together, the support group picture that you showed, you know, I think we're all tired of Zoom and virtual meetings. On the other hand, it's allowed us a connection. You know, I think one of the long-term, sadly to say, benefits, I mean, there's always some kind of silver lining. This has been absolutely horrific. And my heart goes to those that have suffered with this and have died of this. I think of colleagues of mine that have passed away on the front lines. And yet, I think going forward, it's teaching us of that critical importance of connection to each other. And even, as you mentioned earlier, the video consults and the video connections we have with our patients, in some ways, although I much rather be in front of them, it has been wonderful to see them with their pets in the background or their you know, in their own family rooms. In many respects, I almost feel like I'm being invited into my patient's home when I meet with them on a video basis. And these might sound like small emotional things, but we need to be connected through this. This is such an isolating time. It's so important for us to find our way of connection. Some people prefer it over the phone, some prefer it over video or FaceTime or social media, whatever it is. But we absolutely need this. And I really commend those who have worked so hard to do that. And I hope in the long run, we'll be able to, we obviously still have to see patients physically in the clinic and have meetings as the IMF convenes them and so on. But we're learning a virtual format that can be an add-on to that face-to-face format. And I'm really encouraged by that.
Yes, and I've actually had very positive feedback from a number of patients who are using the virtual meetings. They have committed time with the doctor, which they love, and which is often not the case. The doctor's not running off down the hall to do something else. They have that committed time, and the doctor can see the patient can see the doctor, and there is that committed time to have a personal and detailed review. So it is positive. One question that came in is, in talking about getting IV Zometa, there's nothing wrong with the Zometa. The Zometa is not a negative risk factor. It's just the risk of coming into the clinic and the possibility of getting the COVID-19 exposure. But there's no indication that Zometa is a problem to take it. And so if you happen to have been in and got your Zometa, that's not a problem. Okay, so let's go forward to the final area where it's also quite encouraging to see what treatments do we have. As I think Bill mentioned, we will need to do social distancing until we have a vaccine and or until we have treatments that work against this darn virus. And so, although on slide number 28, I'm indicating remdesivir is an active antiviral. It certainly reduced the number of days in hospital for some patients from 15 to 14 days. It's a step forward. And there's just a report actually today from Asia where a combination of 3 antivirals are starting to work against COVID-19. And so I do see a way forward towards a kind of cocktail which we've become familiar with in the treatment of the AIDS virus, actually. And so it's just a matter of how much time will it take to have that. It's pretty interesting that selinexor, just recently approved for the treatment of relapsed myeloma, does have antiviral properties, and trials are going on or getting started all across the U.S. and, in fact, globally. The use of the plasma infusions is phenomenal, and we've already been seeing benefit in a few patients where the infusions have really produced dramatic recoveries. There is a group, a partnership which includes Takeda, where they're looking to develop hyperimmunoglobulin, where they would collect up the antibodies in a more compact fashion as treatment, which is great. Tuberculosis vaccination, this is a type of vaccination that stimulates the macrophages, the kind of garbage collectors in the bone marrow, the ones that scoop up the virus and destroy them. If you can make them more active using BC vaccination, that may work. in countries where BC vaccination has been routine, it seems that there has been fewer problems. And of course, we're all waiting for the vaccine to come along. I've been personally most interested in the group in Oxford in the UK, where they're using the RNA approach, the messenger RNA approach, which makes it a lot faster to develop the vaccine. And we'll see there are over 100 efforts to have a vaccine. And so one has to hope that one of them is going to pay off and be available in the not too distant future. Just a little bit about what's going on. Myeloma patients have questions about the antibodies and the immunity, because that's what myeloma is all about. And so if we look at slide number 29, when the virus comes in, it is taken up, and then the RNA from the virus is used to make a new virus. And so this replication after the uptake, you can see there on the top slide that ACE2 receptor. The ACE2 receptor is where the spike protein of the coronavirus, which is that like a golf tee on the outside of the virus, it attaches to the ACE2 protein. The cell gets in, it makes lots more RNA, and then the RNA makes a whole new virus. And so if we move forward, that new virus is then presented to the immune system. And so it's presented in two ways. One, where antibodies are produced, and so those same kind of B cells and plasma cells which make myeloma protein, the ones which are uncommitted are exposed and can start making antibodies against the COVID-19. But at the same time, the virus is hopefully getting destroyed by cytotoxic T cells and also by macrophages. And so that's why there are different factors in the immune system that can influence the course of the disease. It's not just the antibodies, but they are terribly important. And so as we move towards the summary for the COVID-19 crisis right now, what will the new normal look like? Well, on slide number 31, I've chosen to call it the new abnormal, because I don't think it's ever going to be quite the same. And this is really sad to see, is that things, I think, may have changed forever in a slightly different direction. We will need to pay a lot more attention to physical distancing for quite some time. This virtual social networking will become very important. All kinds of testing will become important. I think just how that will evolve remains to be seen. Right now, it's so important to determine where the virus is so that we can be careful to avoid communities where infection rates are high. Masks in public, I think, will become the standard. Regular masks are becoming more available, but certainly a fabric mask can be used. Telemedicine, it will be the new abnormal. It'll become the normal. And for myeloma patients, the treatment paradigm will evolve, but as Joe has emphasized, we want to stick as close as possible to what we would recommend. We don't want to be cutting back with IV treatments that patients really do need. For traveling, I think that is going to be severely limited, and it's going to be important for all patients to have a good way to get to and from the clinic and to limit other kinds of travel, except to try to get a little bit of vacation for sanity. And so a question that comes up, can I get through this without getting the infection? Well, I think that if you're staying home and taking precautions, every hope is that you can. The key is to avoid becoming part of a local cluster. And the goal, like in New Zealand had the goal of eliminating the virus. So they shut down all travel, and then they traced all of the new cases, and they got their new case level basically down to zero. And so they have a population which is currently isolated because they're not having any travel in or out, but they have a very low percentage population infection level. And so for them, the vaccine will be a key part of it. for all of this information, the IMF has created a myeloma patient safety page, and you can log on to that, and we really do have a lot of collected information that we hope will be important and useful for everyone. And let me just skip forward to the next segment, and we'll have a final Q&A. The final thing that I want to emphasize as we're looking to the future is that we want everyone to be resilient. Now, this seems like it's become an overused word. Everyone says, well, the healthcare workers are resilient, and we are so blessed that that is the case. The healthcare workers have saved so many people. But the myeloma community and individual myeloma patients also need to be resilient. Now, some people are resilient, but most of us need a little bit of coaching to get to be as resilient as we might be. So the first thing is to say, okay, this is a challenge. In what way is it challenging? In what way does it affect me? In what ways does it affect my family? And how in the world are we going to work through to get through this together? And so it does take some time and some focus and a lot of work, actually, to come up with what are the best solutions to stay safe and to stay sane and to try to have some degree of normality. But I do have confidence, despite the fact that there have been a lot of issues in the management of the COVID-19 that we've seen across the U.S., we will get through this together. And myeloma has no borders, and I do love the comment by David Hockney, who released a number of his paintings recently, is that you cannot cancel the spring. You cannot cancel the spring. The world goes on, and we will catch up with the world. And as was written in the sky by a couple of planes 2 weekends ago, we will get through this together. And we need to stick together and think together and plan together. And if you haven't understood some of the stuff that I've been saying, we have a listing of acronyms and myeloma terms and definitions, and you may need these more as we move into the second session. But perhaps we can have some closing comments and questions for this first COVID-19 session. So perhaps Bill, what are your big picture thoughts moving forward into this new world? How do you see your myeloma clinic looking in the next 6 months to a year?
Well, I think the clinic will continue because, as you point out, myeloma knows no borders, and patients will continue to be diagnosed and continue to need treatment. But we're going to have to make changes to adapt to this virus. I think telemedicine, as we've talked about, is going to become much more important. The universal precautions that many myeloma patients already know are, if anything, going to be more widely adapted, and patients will double down on that to protect themselves. But I think, as Joe has pointed out and you have pointed out, this is not a situation where you want to delay treatment. If you need treatment for active disease, don't delay this because of your fear of this virus. It's much more important that you get treated properly for your myeloma than worry about the risk of this virus.
Thank you. Yes, I fully agree. And so, Joseph, maybe you comment from your nursing perspective and community extensive. What do you see in that area? Because nursing is a key part of the supportive care and the management for myeloma patients when they come into the clinic setting.
Well, in Chicago, Brian, we follow strictly the guidance from the mayor and the governor. We are definitely at the mercy of their order, and we have had some issues with some of our youth who violated some of the social distancing and got some tickets. So we definitely strictly adhere to what the city is telling us to do.
Yes, absolutely. Okay, so Joe, what are your thoughts moving forward? I think we need to have a new big picture that is going to emerge, which is not quite like the old picture for taking care of patients with myeloma.
Yeah, I think you're absolutely right, Brian. And I think this last hour has been balanced. I think there's the part of us that fears the severity of this infection. We have to respect it. But then there's also the reality that in the overwhelming majority of situations, we can take precautions to not get it. And hopefully we, as I say, we won't have to treat it. I think looking forward in the myeloma community, I feel in some ways, I know it's been overstated, but, like after 9/11, tragically, so many things changed in our lives. And there's the short-term change and the long-term change. And I think in the short term, kind of like after 9/11, remember, all sorts of things were altered quite dramatically for 6 to 12 months. I think over these next 6 to 12 months, we will have some significant changes. More telemedicine, more physical distancing, extra precautions. But I do also want to balance that within the long term. I really do believe there is going to be a day where we're going to go back to sports games again. We are going to be able to, obviously with certain precautions, you may have to get used to every time you walk into a store that you use hand sanitizer. You may have to be accustomed to certain gatherings being limited in size. But I'm also not of, maybe just because I'm a positive person by nature, I don't sort of feel like the rest of our lives are going to be hung over this COVID. I really do think there will become a time again where if we're smart about it and with the way we're developing vaccines and the way we're aware of what's happened here, that we will return to a near normal life. In the short term for our myeloma patients, we want to take every precaution. But I'm going to conclude by saying one more time, we can't, as someone told me in an analogy this week, if a lion is about to pounce on you, you're not going to be afraid if there's something in the bush that you're going to jump into. We have to deal with myeloma. And thankfully, we've had, as we're going to show right now, these amazing treatments to take down this disease, to control it, to give people a better quality and quantity of life. We don't want to dilute that down for fear of something that we can almost always avoid.
Absolutely. So could not agree more. And one point that has come up is that particularly right now, it is important to seek guidance from a myeloma expert. And so often we say if your local doctor is a little bit uncertain about some of these things that we have been talking about, I think, as you said, Joe, using telemedicine, you can have these consultations which are actually very effective. And so I would certainly encourage patients to reach out if there are questions and concerns to maybe get that telemedicine interview. So this is actually a plus where, instead of having to travel across the country, this idea of getting a telemedicine consult might become a way of the future, and certainly quite important to get advice about.
Can I just add, Brian, that's actually what's been happening to me over the last several weeks. There are patients who wanted to see me, but were unable to do so because of their either inability to travel or perhaps hesitancy to travel. And I'm doing, I'm not trying to be a commercial here because we're always busy, but, I'm seeing many consults now remotely with video contact, with the records being sent in advance, through our electronic health record system. And patients who otherwise could not see a myeloma expert are being able to do so. And we partner well with someone's own oncologist. A patient shouldn't be afraid of that because if anything, it's a team effort, as we've always said at the IMF, that is going to be able to take care of people's myeloma.
Yeah, so thank you for that, Joe. And so please reach out to Joe, or actually reach out to any of us directly, and certainly always feel free to contact the IMF, email the IMF, call the info line, and we will try to help connect you, maybe just give you the information that you need or connect you with people that might be able to advise and guide you. So.